Thank you to the organizers for inviting me to speak and to the audience for coming to listen. So first, let me disclose that I'm a principal investigator on the COSME trial, which is funded by Johnson & Johnson, as well as the ARMS trial, previously funded by J&J and Covidien, but now entirely funded by NIH. This audience knows well that most types of metabolic and bariatric surgery cause remission of type 2 diabetes in the majority of cases, and it's become very clear in recent years that this is not just because of the secondary consequences of weight loss, but also because of many powerful and diverse additional weight-independent anti-diabetes mechanisms that are engaged by various operations. What I'd like to talk about today is whether we can add to the list you see here another new weight-independent anti-diabetes mechanism. The question at hand is whether metabolic surgery improves diabetes, at least in part, by reducing adipose tissue and/or systemic inflammation. And the background for this is that obesity is associated with increased white adipose tissue, or WAT, inflammation. This takes the form of both an increase in the number of inflammatory cells that infiltrate adipose tissue and also activation of those cells to produce increased inflammatory gene products. Targeted ablation of certain pro-inflammatory genes can improve glucose tolerance in obese mouse models, and this has led to a popular model that goes like this. You get obese. Obesity causes an increase in recruitment of inflammatory cell types into the fat. They become activated to produce more inflammatory cytokines. These spill out into the circulation and then act at a distance to increase insulin resistance in both liver and muscle, leading to diabetes or contributing to it. The limitations of that model are that most of the convincing data come from mice, and primarily the data in humans are associational rather than confirmatory. Now, in theory, you could probe this model and see whether it works in humans using metabolic surgery as a tool, but prior studies of that have looked at metrics long after surgery has been done, when you get very confounded between what are changes that come from the operation itself versus secondary changes from the weight loss that the operation caused. And no one has yet looked at adipose tissue inflammation after metabolic and bariatric surgery compared to individuals who've lost the same amount of weight with a non-surgical intervention. So in the first study I'd like to show you, we asked the question, does Roux-en-Y gastric bypass, RYGB, decrease adipose tissue and/or systemic inflammation more than does equivalent non-surgical weight loss with a diet and exercise? And the hypothesis was that it might do so. So for this study, adults with obesity and type 2 diabetes were recruited and then randomly allocated in an RCT to receive either a very intensive medical lifestyle intervention of diet, exercise, and state-of-the-art diabetes medications, or a standard gastric bypass with no special no special lifestyle intervention. After being randomized into these two study groups, both were studied at baseline and exactly when they had lost 7% of their body weight. Obviously, that occurred earlier in the surgical group than in the medical lifestyle group. And at those 2 time points, what we measured were subcutaneous white adipose tissue biopsies and fasting blood tests. The biopsies were then subjected to flow cytometry. They're first dissolved by collagenase to get rid of the adipocytes themselves and isolate just the stromovascular cells, which was where you'd see inflammatory cells. These were then subjected to flow cytometry and stained for at least 10 so-called CD markers, plasma membrane proteins that can help identify the cell type. And through this, we were able to quantify the number and the percent of each different cell type in the stromovascular compartment of adipose tissue. Those cells were also subjected to gene profiling, so we were able to determine the quantity of genes that they were making in terms of pro-inflammatory genes, such as TNF-alpha, tumor necrosis factor alpha, interleukin-1 beta and interleukin-6, monocyte chemotrectin protein 1, intercellular adhesion molecule 1, and the anti-inflammatory molecule adiponectin. The blood tests that were done were in 2 broad categories. One was looking at inflammatory biomarkers, and the other was to look at metrics of glucose homeostasis. Now, the stromovascular cell types that we were most interested in were those primarily associated with adipose tissue inflammation and metabolic derangement. So from prior literature, that includes leukocytes, neutrophils, macrophages, both helper and cytotoxic T cells, and dendritic cells. The last of these are thought to be antigen-presenting cells in adipose tissue. So the kind of data we get look like this from flow cytometry. So in this particular case, First, having collagenase digested the tissue and gotten rid of the adipocytes, the remaining stromovascular cells are subjected to two analyses. One is a method to determine whether they're alive, and then they're stained with CD45, and if they're alive and CD4 positive, they're considered living leukocytes, in other words, white blood cells. Then you separate those leukocytes away from the dead cells and the non-white blood cells, and further stain them with another marker, which is called can't even read it from here, but CD23. And if they're positive for that, then they're identified as T cells. The T cells are then separated out, and then further stained with CD4 or CD8. And if they're both CD3 and 4 positive, we define that as CD8 positive and CD3 and 8 positive are considered cytotoxic T cells, and those that are CD3 and 4 positive are considered helper T cells. Now, separately, in a different compartment, we take living leukocytes and co-stain them with CD15 and 16, and if they're positive for both, those are considered neutrophils. Then we separate, in addition, living white blood cells, and if they're stained positive for both CD1C and CD11C, those are considered dendritic cells, the antigen-presenting types. And finally, in a separate category, those that are living white blood cells that stain positive for both CD206 and CD14 are considered macrophages. Now, we didn't make up these ways of identifying stromovascular cells. That's from the extensive literature in the immunologic domain. We just used this to quantify what kind of cells were in our adipose tissue biopsies. The randomization protocol was successful in getting groups that were identical at baseline for most of what we measured, everything related to demographics, anthropometrics and body composition, fitness level, glycemia, lipids, and blood pressure were identical in the two groups at baseline, with the sole exception that by chance the surgical group had longer duration of known diabetes than the medical group, introducing a conservative bias against surgery doing better on diabetes. And in a different paper, despite that bias, surgery was much, much more effective than medical lifestyle intervention, even though the latter was very intensive for getting rid of diabetes. Importantly for this study, the groups were also equivalent at baseline for plasma markers of inflammation such as CRP, TNF-alpha, IL-6, adiponectin, and others. So here are our results. By design, the two groups lost equal weight because that's the way it was set up. So they were both studied when they lost 7% of body weight, either with a diet and exercise or with surgery. Despite equal weight loss between the groups, the improvement of glucose homeostasis was greater after gastric bypass than diet and exercise, as measured by the fact that although the two groups had equal reductions in fasting glucose and insulin and HOMA-IR, this was in the context of much greater reduction in the surgical group in the use of metformin and insulin. So now we can ask the question, was improved glucose homeostasis associated with the cleaning out of adipose tissue inflammation in either or both groups? And what we hypothesized is that it would be disproportionately cleaned out in the surgical group compared to the medical group despite equal weight loss. So let's look at some cell numbers first. Let's look at number of neutrophils, and this is going to be expressed as cells per gram of adipose tissue. To our surprise, neutrophil number increased in the weight loss associated with gastric bypass. And to our greater surprise, they went through the roof in the same amount of weight loss with the medical lifestyle group. That was not what we expected. What about another cell type? CD4 positive T cells. These are helper T cells. To our surprise, those also increased with 7% weight loss, and to an equal degree in both the medical lifestyle-induced and surgical-induced weight loss. Looking now at gene expression, this is expressed as mRNA copy number normalized to a housekeeping gene. To our surprise, interleukin-1 beta, as an example, increased with 7% weight loss in both groups and to an equal degree. And the anti-inflammatory gene, adiponectin, surprisingly decreased in both groups, but to an equal degree. Some other results in terms of things that didn't change. We did not see changes in adipose tissue macrophage, dendritic cell, killer T cell number. We did not see changes in the following pro-inflammatory cytokine genes, TNF-alpha, IL-6, MCP1, or ICAM1. And we did not see changes in systemic markers of inflammation such as CRP, IL-6, and adiponectin at the time point studied. But to reiterate, the things we did see changes in that surprised us were a great increase in the number of neutrophils in adipose tissue with 7% weight loss in both groups, especially with medical lifestyle weight loss, an increase in helper T cell number in both groups to an equal degree, an increase in IL-1 beta gene expression in stromovascular compartment of both groups to an equal degree, and a decrease in adiponectin gene expression in both groups to an equal degree. Now, those are the 4 positive findings, and all of them would be pro-inflammatory, or at least you'd think so. So this was surprising. Scratching our heads about this, we thought, okay, maybe we can explain this at least in the surgical group, because 7% weight loss does not take very long to achieve after a gastric bypass. So we're looking at people fairly soon after surgery, and maybe they're still inflamed from their operation itself. So then we went and did a separate study. So this is a completely different study, different publication, different cohort. In this one, we asked the question, does decreased adipose tissue inflammation contribute to either the short, i.e. 1 month, or longer, 1 year, effects of metabolic surgery? So the design of this was that people with obesity and no diabetes were recruited to the study, and they underwent either a sleeve gastrectomy or a gastric bypass. This was a larger study, and it was not randomized. It was just looking within surgery. These people were then studied at baseline 1 month and 1 year. And at all those time points, they underwent, again, subcutaneous adipose tissue biopsies, fasting blood tests, and in this case, an oral glucose tolerance test to further characterize their glucose homeostasis. The biopsies and the blood tests were subjected to the same things we did in that first study. So the weight loss was good, 13.5 kilograms at 1 month, 35 kilograms at 12 months in the surgical patients. And not surprisingly, glucose homeostasis improved, especially at a year. This was reflected in a decrease in the area under the curve glucose with an oral glucose tolerance test, which you can see there, seen at 1 month and a tiny bit more at 1 year. Also an increase in the estimated insulin sensitivity, which was roughly estimated by both HOMA-IR and Matsuda index. An increase in beta cell function as judged from the insulinogenic index. An increase in oral disposition index. And decrease at this point in the 12-month time point in inflammatory biomarkers such as CRP, IL-6, and an increase in the anti-inflammatory marker adiponectin. So these systemic changes are more what we expected, but we only saw them when we waited a year. So how does that improvement in biomarkers of inflammation at a year jive with what we saw in adipose tissue? Did that get cleaned out? So let's look again at number of neutrophils in the adipose tissue. Like before, at 1 month, we saw a big increase after surgery. That's about the same time point as we did it for the 7% weight loss study. But to our surprise, it was consistent at 1 year. So that really rules out the idea that this increase in neutrophil infiltration in adipose tissue after metabolic surgery is because of some generalized inflammation from the operation itself. That should be gone by a year. Similarly, macrophages in adipose tissue were up at a month and stayed absolutely that high at a year. Also, helper T cells, up at a month, at least as much at 1 year. Killer T cells, up at a month, still at least as much at a year. And like before, the dendritic cells were unchanged at a month, but waiting a year, they're up too. So those are all pro-inflammatory cells who are increased with weight loss following surgical intervention, and you cannot impugn sort of generalized surgical inflammation as the reason because it lasts for a year. In this particular study, we saw no changes in adipose tissue inflammation by gene expression, and you can see the genes tested there. So a summary of both studies. They're not entirely consistent on every parameter, but the broad sort of summary of both is that the improved glucose homeostasis seen after bariatric metabolic surgery occurs despite, if anything, increased adipose tissue inflammation. So we cannot add a magical cleaning out of adipose tissue inflammation as one of the means by which metabolic surgery magically gets rid of diabetes. Probably the more important finding for this, for the general field of diabetes, is that this challenges the prevailing model of a necessary causal link between adipose tissue inflammation and the regulation of glucose and body weight, which a model that has been primarily based on rodent data. And so this raises the question whether those rodent models are an accurate reflection of human data. I thank my many collaborators from the University of Washington and the Group Health Research Institute here. They're listed here, especially Mario Kratz, who's the leader on this, and then Dave Flum was also a co-PI on the parent Crossroads trial from which this was generated. And that's what the chat looks like when it's not raining.